I never know if this circle is telling me I'm not on yet or not. So I think I'm live. Every time I watch one of these, it looks like I hesitate a little bit. So hopefully we can get through this in that 30-minute time slot I have for me usually. Okay, so we're going to talk about pharmacogenomics. Pharmacogenomics, pharmacogenomics. Good morning, Linda. And pharmacogenomics, despite being a multi-syllabic word or multi-syllable word and hard to pronounce, is actually just a combination of pharmacology and genetics. And it arises or has arisen from the Human Genome Project. So the interesting thing about studying genomes is figuring out how your genetics affect your response to medications and disease processes. Most of this is used a lot in cancer therapy. So it's been used in colorectal cancer and breast cancer patients to decide whether or not a medication will actually fit a person's DNA. So remember, DNA is the code for your body making proteins. And proteins are involved in cell membranes and synthesis of various substances in your body. And the pharmacology industry or pharmaceutical industry, I guess pharmaceutical, not pharmacology, is the study. Pharmaceutical is the implementation of pharmacology in a real-world setting using medications. Morning, Christy. So pharmacogenomics is actually looking at both of those. So when you're looking at the pharmacology part of how medications work, there's a role of two things called pharmacodynamics. And pharmacodynamics is the study of how a medication actually works inside of you. Okay, so pharmacodynamics involves the receptors that may be used to get a medication into a cell, and then there's ion channels, so potassium chloride pumps, sodium, potassium, hydrogen, etc., or the ions. So there are channels that will bring medications into a cell to allow them to exert their effects. There are enzymes that are involved, and then your immune system. So that's pharmacodynamics. And then pharmacokinetics looks at ADME, so absorption of a medication, distribution of a medication, metabolism of a medication, so breakdown, and then excretion. So once the medication has done what it needs to do, then it has to be excreted, whether that be in stool or in the urine. Most of the time in the urine. Okay. So also bile, sometimes exhalation, so you can exhale medications that have done their thing in your breath from your lungs as well. So, and liver enzymes have a lot to do, most everything you put in your, especially medications, but if you distribute or ingest a medication orally, it's going to go through your liver. So the people that like to avoid, for instance, oral hormone replacement, their thinking is if you give the medication sublingually or as an injection or as a topical cream, you actually bypass the liver's cytochrome P450 system, which has to do with either turning on and turning off a drug and metabolizing and excreting a drug from your body. So pharmacogenomics is involved really with how your genes affect your body's response to medications. So it's combined from the words pharmacology, the study of the use and effects of medications, and genomics, which is the study of genes and their functions. And you get two genes from each parent, so theoretically you can't just say, well, I'm going to give this medication and it's going to work on all the millions of people around the world. there clearly has to be some genetic variation on how people respond to medications. So finding the right medication is part of the reason for pharmacogenomics and testing. PGX testing is kind of how it's shortened, so you don't have to say pharmacogenomics. So PGX testing that can help a healthcare provider determine the best medication for you. So it's been used in personalized medicine. So if you, in functional medicine, doctors are kind of the people that do the most personalized medicine that I've seen. So you also have to consider other factors such as your age and your lifestyle, and then other medications that may have interactions. So when the Human Genome Project started looking at the genetics, or the PGX part of how people's DNA works with medications, they got all excited thinking, okay, this will be perfect. It'll be a roadmap. This is exactly what we need to test every person on Earth for, and especially if they're going to be put on a chronic medication. Turns out that it's not quite that simple. It would be great if it was that simple, but it's not, because you do have to take into account the other factors such as age and lifestyle, what you're doing, if you're smoking, etc., how physically fit you are, and then the other medications that may interact, including supplements. So when we look at supplements, we always have to think about, okay, how are they going to interact with the prescription medications that people are using? And that's part of the art of figuring out what supplement for what person, right? Okay, so my favorite story of PGX testing, and I started doing this about 2013. They weren't cheap, but when nothing would pan out, so we would talk to men and women that had chronic problems, usually pain related. It was almost always pain, and their response to pain medications, if you did a PGX test on them, you would find out, oh, well, you're taking oxycodone, and that doesn't fit your DNA profile. That's why it doesn't work, and you have to keep escalating your doses. They've looked at this with codeine a fair amount. And the way you metabolize. So codeine really is metabolized to a form of morphine. And codeine is actually a fairly powerful narcotic, but not everybody responds to it the same based on their PGX, their genome, their DNA. So for some people, they rapidly metabolize it and they get side effects. So you have to lower the codeine dose. And for other people, they slowly metabolize it. And sometimes you have to increase or decrease. It just, that's part of the art of medicine, is figure out, okay, how are they metabolizing? How does their DNA fit with this medication that I'm using? And how do I adjust the dose for that person? So that's the personalized medicine aspect. So back to my favorite story. I took care of a guy in Oklahoma City few years ago, and he tends to pop on here occasionally, so he may recognize his story. And of course, I'm not going to use his name, but he is a power lifter, very strong guy. He doesn't compete, but he's very physically fit and physically in good shape. The problem for him was he had chronic low back pain. That came from a car wreck in which he had a back injury that did not require surgery, but he did have like a lower back strain, or it's called dorsalgia. That's chronic low back pain. And no matter what he did, he could not rectify that problem. So when he saw me, he was seeing me for testosterone replacement, so that he was being monitored, instead of so many powerlifters that just take testosterone willy-nilly and don't get monitored for it, and then they get in trouble. So this guy was on oxycodone, and then there was one other, and I'm blocking the name of this really expensive muscle relaxer. And he tried different doses, he tried different doctors, etc. The testosterone didn't make a difference. And of course, he was powerlifting, so that probably wasn't helping his back overall. But the rest of him was in great shape. I mean, he was just in good shape. So I finally talked him into a reasonably expensive PGX test. It wasn't covered by insurance. This is 2014. And I think his PGX test cost him, I think, $400. I've seen him as high as $1,200. I've seen them as low as $250. So there's the cost factor. And it is FDA approved. It's not always covered by insurance unless you pick a specific medicine. So if you say, okay, I want to test how this person would react to simvastatin, a statin. So PGX has been used to figure out how to dose or whether or not a statin actually works in an individual. For a doctor that's considering putting a person on a statin, which of course I never did, hardly ever. There's better ways to do that. We talked about that a month or so ago. Okay, so this guy did a PGX test on him. It was a very simple cheek swab. So you take out what looks like a little Q-tip that's in a kit that you get. So I just kept them in the office. And you would literally put the Q-tip against the cheek on each side for 30 seconds and just kind of roll it around. So you're getting DNA from cheek cells and saliva. You can do it as a blood test, but if you have a choice, the cheek swab is pretty simple to do and it doesn't hurt. You're not sticking it in their throat or up their nose or anything. And so we got a profile on him, and they measured all these different, let's see if I can find these for you. It's a big gobbledygook of letters when you're looking at PGX testing and the DNA that they're actually testing. There's a couple that are the most common. And of course, here we go. So drug gene testing. So we did I think this was a CYP2D6 test on him. That was part of it. So there was 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. We did 16 different genetic screens for all the different classes of medications for him to try to figure out how he responded to each one. Well, it turned out that the narcotic that he was taking, Percocet, I believe, so that's a variant of oxycodone that has Tylenol in it, his DNA didn't process. It was totally ineffective. Now, it wasn't a warning. It comes up as a kind of a warning, hey, don't use this medication in this particular person because their DNA doesn't do anything with it, doesn't know what to do with it. So theoretically, you could overdose a person, especially with an opiate, a narcotic. You just keep giving more and more and more and more because you're not getting the effect. And you're not getting the effect, at least for this guy, because his DNA didn't know how to process oxycodone. And then that other big expensive muscle relaxer, he also didn't process that. And that was an out-of-pocket cost for him, about $150 a month. Well, it turns out that he had been doing that for, I think, a year and a half. He told me he'd been taking that medication at $150 out of pocket, and it didn't work because his DNA didn't know how to process it. Genetically, his body rejected that drug, and it didn't do anything. So of the list of the muscle relaxers, the one that worked the most, and of course is inexpensive, was Valium, or diazepam. So we put him on 10 milligrams of Valium, generic Valium, and he got 90 of those for $10. And then he would take it PRN, meaning if he needed it. So if he felt like his back was flaring up or his muscle spasm was flaring up, he would take one. He didn't do it 3 times a day routine because that makes you dependent. And then the same thing, we put him on codeine instead of oxycodone because codeine fit his DNA profile, and really a low dose of codeine, and he was fine. So that's the power of PGX testing. You can take that information and figure out what does this person need for this issue and which medications actually fit their DNA, right? So there's all kinds of stuff that you can do with gene testing and PGX testing. It's your response to medications. You got thousands of genes. I told you about 15 of them, and I'm not going to read them because they're ridiculously hard to pronounce, and they're all letters and numbers. But I'm sitting here looking at a pharmacogenomics testing from the Mayo Clinic, and this is on their website. So drug gene testing, if you recognize any of these medications, it'll tell you, there's a way to tell you if they're effective. So citalopram, clopidogrel, which is Plavix, escitalopram, warfarin, that was one of them that is pretty routinely done. So Coumadin for people that have had pulmonary emboli or that have atrial fibrillation fairly often are on warfarin. And if you do the PGX testing on warfarin, you can figure out how to dose that person so that you don't get them in trouble. Too much warfarin, you can bleed out from a nosebleed, right? Codeine, fluoxetine, which is generic Prozac. So it's been used in mental health. So the SSRI, selective serotonin reuptake inhibitors, which is Paxil, Zoloft, Prozac, all the SSRIs, you can test every one of them with a PGX test. And then if somebody feels like, if a physician feels like that person needs to be on an SSRI, you can pick the right one for that person and then dose it accordingly. Fluvoxamine, paroxetine, tamoxifen, that's used in breast cancer. Also used in, well, it's an estrogen blocker, so people that have had estrogen-positive breast cancers are usually on tamoxifen for life. Well, there's alternatives to tamoxifen, so it'd be nice to know if you're taking something to prevent recurrence of breast cancer, whether or not your body actually knows what to do with tamoxifen, right? Tramadol, very commonly used for chronic back pain or just chronic pain syndrome in general. That's an easy one to get dependent on, and it's hard to come off of. The withdrawal of tramadol can be bad, and you can kind of predict who's going to respond what way to tramadol with PGX testing. Then laxifene, carbamazepine for seizure disorder, allopurinol for gout, simvastatin, and the thiopurines. That's what's listed right here on the Mayo Clinic's Center for Individualized Medicine. So even the Mayo Clinic is starting to figure out that individuals have different individual responses to medications and medical interventions, right? So the kind of problems is how do we take that information, or should everybody have that test done? Well, you'll get some fight back. I've had many physicians, usually family medicine doctors, argue with me about doing PGX testing. When I brought that up to a patient, maybe I was doing a consult on, I'd say, why don't you do a PGX test? And they'd say, no, that just doesn't make any sense. Well, theoretically, if you did the test, you would only do it once, right? So if you had a big list of medication types, and of those types, which medication fits your DNA, then as a physician, if you're considering a treatment with just an antibiotic, you can pick the right antibiotic for the right disorder based on a person's genes and their DNA and their response. So that's kind of the power of PGX. Not everybody gets into it, and a lot of doctors, I don't think, maybe have even heard of it or know that you can do it. So the FDA has approved, and medical insurance has approved testing for specific medications. Doing a test for all the different classes, I think, makes a little bit more sense. I mean, if you're, let's say that you went in and you had a PGX test because they were going to put you on Coumadin, and then 2 years later they go, okay, we're going to put you on Prozac, and you have to have another PGX test if you just did the test, and of course insurance won't pay for that because it's not medication specific. Okay, so if you just do the PGX test once, theoretically you would know forever how you would respond to different classes of medications. So you would do it once, right? The problem is they're always coming out with new medications. So if a physician was thinking about putting you on a medication that you hadn't been PGX tested for, you would have to do it again. But once you do the PGX test and those medications are listed, it doesn't change. Your genetics don't mutate while you're alive. Your genes are your genes, and your DNA profile is your DNA profile. So the variation of genes can help predict a greater risk of side effects, needs for higher doses or lower doses to achieve a therapeutic effect, or whether or not there is no benefit from the treatment at all, like the powerlifter guy I was telling you about. No benefit at all. He took these two medications. Soma was the other one. Soma was the muscle relaxer he was taking. Had no effect because his DNA didn't recognize it. Or maybe a greater or more likely benefit from a treatment, or even the optimal duration of treatment. So if you know all that, then you can probably figure out how to dose and treat accordingly, right? That's the whole point. So from the CDC has a page called Pharmacogenomics, What Does It Mean for Your Health? That explains it. It goes through the drug receptors and an example for breast cancer, and a medication called TDM1 based on a HER2 receptor, whether or not that will work or not work for you. They talk about drug uptake, so some have to be taken into tissues and cells. So DNA can affect uptake of certain drugs. So if you have a decreased uptake based on your DNA, the drug won't work as well and can cause it to build up. That can cause problems. Then eventually you start getting side effects from the buildup of the drug that hasn't been brought into your cell. The example is statins and muscle problems. And you remember when we talked about statins, something like 54%, if I remember right, of patients have an adverse drug reaction to statins. And one of the more yucky ones is rhabdomyolysis and muscle problems. Well, PGX testing will tell you that, okay? There's a specific changes in genes that cause less of statins to be taken into the liver. And then when it's taken at higher and higher doses, because you're not getting a response from it, potentially you've got a buildup in the blood that can then cause muscle problems, if not rhabdomyolysis, which is horrifying, at least pain, myalgia, or weakness in those muscles. So before prescribing a statin, I told you that guy in England thinks 1 in 3 people in the entire world should be on a statin. Well, what if you're taking a statin and your body doesn't recognize that and you get those side effects? It's like over 50% of people just stop the statin because of side effects. And then drug breakdown. Okay, so the DNA can affect how quickly your body breaks down a drug. You may get rid of the drug faster, you may get rid of it slower. So the example from the CDC is depression and one of the tricyclic antidepressants called amitriptyline, which interestingly enough can also be used for chronic pain in low doses. It works fairly well, like 25 milligrams a day. So the breakdown of amitriptyline, and there's a whole class of tricyclics, they're not all SSRIs for depression, are influenced by 2 of these gobbledygook letter and number genes. And so if you genetically test before you put somebody on tricyclic, you may need a higher dose if you break it down too fast, or you may need to use a lower dose if you break it down too slow. Or if you don't respond to it at all, you just wouldn't use it, right? Okay, other things are targeted drug development. So if you know PGX and you know the genome, then you can target an underlying problem rather than just treating symptoms. And that's kind of the hallmark of personalized medicine or functional medicine. So instead of just saying, well, you've got this symptom because of this issue or this illness, and you get a drug for a symptom, why don't you go for the target illness and try to figure that out instead of just prescribing a whole bunch of medications just for the symptoms of an illness that you haven't figured out why they have, right? So drugs can be created based on how a mutation affects the protein and how certain drugs will only work for a specific type of mutation. And if you know that mutation from PGX testing on a person, then you can develop medications that are actually more specific. So there's the example from the CDC is a medication that they're for development for use in cystic fibrosis patients. Okay, so it's only used technically for a few drugs. Okay, so the CDC and the FDA, I think there's 200 that they say this is actually important, helpful information. But there's more than 200 medications on the market, right? And if you do a PGX test on a person and check them for specific medications in each class, then you can actually be more effective if you think that a person needs to be on a medication in the first place. Okay. Now, the problems with it is you have to take into account that the age and the lifestyle, drug interactions, et cetera, are involved. Then you also have to realize that you cannot be discriminated against based on your genetics. So the FDA has a statement on the fact that you cannot be discriminated against for that reason. So if you know your genetics, they can't say, well, this person has a likelihood of development of this and that and the other thing based on family history and genetics, and say, well, we're just not gonna take care of that. But that is not true for the life insurance and disability insurance industry. So one of the downfalls of doing PGX testing and an insurance company finding out what your genomics are is that they can deny you life insurance and disability insurance based on that information, even though that little statement by the FDA is in there that you can't be discriminated against. So that's why the HIPAA laws are so important. You shouldn't necessarily have to, how much of your health information can be gotten from, there's Bella saying hi, can be gotten from your electronic medical record, for instance. How secure is that? And if somebody can get a hold of that information, what can they do to use it, right? So that is the basics of PGX and pharmacogenomics. It's an interesting field. Started out in the 2000s. It keeps getting more rapid and more rapid. More and more drugs added to the list of, I guess, approved PGX testing drugs that you can do PGX testing before you prescribe a medication. But you can get the test on your own. There's several websites I was looking at this morning, different costs. The ALCAT test I've used for food allergy and food sensitivities. I found a test for that is quite a bit less expensive. ALCAT used to run, I think, $1,200. So I think Friday we're going to talk about food sensitivities and all the things that food and what you put in your mouth and what you eat and what you drink can affect you. There's a way to test that. So PGX testing, like I said, used to be $600-ish. I've seen them around $250 to $500. There's one testing company called GeneSight that runs around $300, and they won't run the test without calling you if it's going to be over that. So they won't do it until they check with you and say, okay, that your copay for this is going to be $300 or $200 or whatever it is. So it's gotten cheaper or less expensive, I guess. Not cheap. Cheap makes it sound cheap, but less expensive. So I'm going to say $299 to about $499, depending on how thorough you want to be. Okay, so that's the little basics on PGX. We'll talk about food and sensitivity or food sensitivities, which is a little different than allergies. On Friday, I'll be live from St. Louis, Missouri. I got to go to St. Louis for a couple days, so we'll do this with a different background. And I will talk to you Friday. Have a great day, great rest of your week. Peace and health to you all, and I'll talk to you Friday. See ya. Bye.